Hello, my name is Jaya Chandrasekhar. I'm an interventional cardiologist, and on behalf of Global CVCT, I have the pleasure today of speaking with Professor Stephen Nicholls from Australia. Hello, Professor Nicholls.
Hi.
So Professor Nicholls is the lead of the South Australian Health and Medical Research Institute. You've previously been based in Cleveland for a long time, and your main interest is translational cardiovascular research, really in atherosclerosis, therapies and modalities to halt, potentially reverse atherosclerosis. So thank you very much for spending time with us today. We're really going to be talking about the Accelerate study. So could you tell us about the main findings of the study and what your interpretations are?
So Accelerate's the large phase 3 outcome trial of evacetrapib, a potent CETP inhibitor. This is the third of these agents to go forward in clinical development. The first agent, torcetrapib, was associated with an adverse effect on outcomes. The second agent, dalcetrapib, which was a more modest inhibitor, resulted in no clinical benefit whatsoever. It was kind of clinical futility. But there was a sense that if there was a potent CETP inhibitor that lacked the type of toxicity we saw with torcetrapib, that would still be a viable strategy for a clinical trial. We did a phase 2 study of evacetrapib and showed that we more than doubled HDL, we lowered LDL on top of a statin, we lowered Lp(a), we increased cholesterol efflux. We thought that was all pretty good. So Accelerate enrolled more than 12,000 high-risk CV patients, treated them with either evacetrapib or placebo. The study was stopped by the DMC in the middle of October of last year due to clinical futility. And so what we've reported here was patients achieved an HDL cholesterol of 104 milligrams per decilitre. That's a little bit more than 2.6 millimoles per litre. That translates to a 130% increase in HDL. The LDL is 55, so that's about 1.4. That's a 37% reduction in LDL, yet there's no benefit whatsoever. The hazard ratio for the primary endpoint is 1.01. Event curves are totally on top of each other. No suggestion of event curve separation whatsoever going out to 3 years. The average time on study drug in this study was 25 months. The average time in the study of follow-up was 29 months. So very good follow-up in this study. No benefit whatsoever. We looked at the secondary endpoints. There's no benefit on any of those. There's a finding that there's less death in the evacetrapib group, but the p-value is 0.06. We think that's more a play of chance than anything. We observed that CRP went up a little bit with evacetrapib. That was statistically significant. There's a significantly higher blood pressure in the evacetrapib group by 0.9 millimetres of mercury. It's statistically significant. Whether it's clinically relevant, we don't know. So the bottom line is, despite fantastic lipid numbers, the drug doesn't reduce clinical events.
So that's very interesting. Thank you for that summary for our audience as well. So you did mention the patient population was a high-risk population. Can you tell us some more about those inclusions? So these are not patients with an acute MI, not patients undergoing acute stenting, but yet high risk. So how so?
That's correct. So you could get into the study one of four ways. You could either have had an acute coronary syndrome, but you had to be 30 to 365 days out from your index event. And we did that because we didn't want to treat super acute patients. It turns out that the ACS patients in the study, and they were about 30% of the patients in the cohort, their mean time from their index event to randomisation is about 5.5 months. So these patients are well out from their event. Peripheral arterial disease, atherosclerotic cerebrovascular disease, and diabetes with coronary disease. And in fact, what we found was that 2/3 of the patients in the study are diabetic. So, it's a really good number. So we will go back and take a deeper dive. We'll be able to learn a lot about what happens in the setting of diabetes in this study.
Thank you. And you mentioned that the CRP went up, not down in these patients, despite the very favourable lipid outcomes. You also mentioned blood pressure went up. And I know that a previous iteration, torcetrapib, I think, increased blood pressure in patients. And we thought this particular drug, evacetrapib, was well tolerated. So do you think these two findings are responsible for no difference in clinical outcomes, maybe?
So I think we're left with a couple of different potential scenarios. One is that something is offsetting a really good benefit on LDL. And if that's the case, well, is it a problem with CETP that we don't know about? Is it a problem with the HDL? We know what we know about HDL, but there's a whole bunch of other stuff about HDL we don't know. Is it the blood pressure? The blood pressure's up a little bit. I would be surprised if that completely counteracted.
How much did it go up?
By 0.9 millimetres of mercury. So I think that's a little hard to kind of blame the blood pressure per se. And the CRP goes up. Now the CRP, again, it is statistically significant compared to baseline, compared to the placebo, which went down, but it's only a very modest, it's about a 5% increase. So again, it's a small increase. Whether that translates to differential effects at the level of the artery wall, whether it makes your HDL less functional, and there's some evidence to suggest that may be the case, we don't know. So that's one explanation. The other explanation may potentially be that just as we don't know everything about HDL as we think we may not know everything about LDL as we thought we might. And here is an agent that lowers LDL a lot and doesn't work. And it really tells us that mechanism matters. Statins lower LDL and they reduce events. Evacetrapib lowers LDL and it doesn't. And now we've got to ask the question, well, what do we know about the LDL? You may have lowered the overall LDL cholesterol, but it may be that the LDL that's left may be particularly atherogenic. So we have spent a lot of time in the last couple of months closing out a prematurely stopped study. We've got the top line data ready to present and share with the scientific community at this meeting. Now we need to go back and ask these types of questions and take the real deep dive to see what we can learn from the study.
So 2 final questions. One, you talked about these patients being unusual care, so they're already on a statin. So what dose of statin were they on? What was the average dose of statin these patients were on? And then the other question is, there's comments about whether we should be enrolling or trying this drug with lower risk patients, or whether in fact it should be higher risk patients now that you have a safety profile. So, those are 2.
Yeah. So everybody was on a statin. 50% of the patients were on high-intensity statin therapy, kind of, 40 and 80 of Atorva, 20 and 40 of Rasuva. So I think we had statin use both in terms of agents and doses, which did reflect the way we treat our patients in clinical practice. The other question, sorry?
So should we be trying this study on lower risk patients? Of course, if you did it in lower risk patients, you'd need an enormous sample size, which may not be realistic. But, should we be trying this in higher risk patients who may benefit more?
So we now have 3 large outcome trials of CETP inhibitors in high risk cohorts, and they don't work. There is one ongoing study called REVEAL. It's run by both the Oxford and the TIMI groups, looking at anacetrapib, Merck's potent CETP inhibitor. It's in 30,000 patients, another high-risk cohort. I think as each of these negative findings comes along, perhaps you become a little less optimistic of the chances that will work, but we'll see. That trial should run its course and we'll see what happens. If you just want to speculate that it doesn't work, however, I think it is a really important question. Is it more likely to work in a much more primary prevention setting, which would be an enormous study? And more importantly, is it more likely to occur in patients who aren't treated with statin therapy? Because there's some sense that maybe there's an interaction there that may not necessarily be maybe competing. And so if there's a future for this class of agents, it may be in that kind of setting, but that's a really tall order to go into that, as you explained.
Well, time will tell. Thank you so much for your time.